and large biorepository of patient and control biospecimens. In addition to generating clinical data to better understand the PANS illness, she is collaborating with 10 basic science labs who aim to understand the immunological underpinnings of the illness. Again, she has no interest to disclose. And then I'll just also add on a personal note how much admiration and respect I have for Dr. Frankovich, for her support for our foundation, and also her personal support for me and my wife as a professional courtesy. She's given us some of her time and given us some guidance from some of the challenges that we face in not only treating our children, but also just navigating the environment around these illnesses. And you know, personal, professional courtesy is just not so common anymore, and she has shown more than most. And so I just want to let her know that we're very grateful for her help. And so in closing, I want to thank you all for participating in today's CME activity. Again, to receive credit, please complete the registration evaluation form at the end. I will repeat that after the Q&A session. And with that, I will turn it over to Dr. Frankovich.
Sure.
Okay. Well, thank you, Dr. Corey, for introducing me and for this opportunity to share what I understand about inflammatory diseases and the presentation of psychiatric symptoms. I am going to talk about PANS, but I first wanted to talk about some other inflammatory diseases. And Dr. Corey already went over with you our 3 learning objectives. And I was thinking that there were going to be people that joined us today that may not believe in PANS or PANDAS, but that, hey, can you shut the door? Sorry. Okay, sorry about that. That may not believe in PANS or PANDAS. But instead of when a patient comes to you or a family, and if the family says, hey, I think my kid has PANS or PANDAS, instead of saying, oh, that's controversial, I can't help you, or that's not a real disease, I want clinicians to actually just recognize that there's organic causes of psychiatric symptoms. And there's other inflammatory diseases that cause abrupt psychiatric symptoms, so that they could just start from that standpoint. Start from the standpoint of, I need to evaluate this patient. That's why I'm going to talk to you about other inflammatory diseases that cause psychiatric symptoms. And if you can learn from those other diseases, I think that you will have a better approach to the patient. Uh-oh. Hold on a sec. Sorry, I'm not seeing how to advance. Hold on here. Hey, Jackie.
Hey, Jenny, I can help you.
Okay.
Dr. Frankovich, what I would do is just restart PowerPoint. For some reason, it's crashed.
Okay.
So hit OK and restart it.
Okay, let me restart.
And then if you go to full screen on it, go back to your slide. We'll hopefully be off and running again.
Okay.
In the meantime, I'll entertain everyone. Can you guys see the fire in my office? It's freezing in Wisconsin. It's going to be like -60 tonight, so I'm getting ready. Anyway, Dr. Frankovich, I think you're up and running.
Okay. Do you see the full screen?
Yes, it looks good from here.
Okay. Let me just try to shrink another screen here. I don't know if I can close that. Okay. Yeah, the problem is it's not advancing. Oh, here it goes. Okay. Perfect. I'm doing a webinar. Yeah. Sorry. Okay, so studies over the last few years have showed a great overlap between mental health impairment and rheumatologic inflammatory disorders. And lupus is a great example. This is a multi-system inflammatory disease where 25% of children with lupus have neuropsychiatric symptoms. Headaches constitute the majority of the symptoms, but these patients also have psychosis and cognitive dysfunction. Neuropsychiatric symptoms can be the presenting feature of lupus, even with few other clinical signs. MRI and CSF studies are commonly normal, or they have nonspecific findings. And interestingly, OCD, which is one of the main criteria for PANSS, is also very common in patients with lupus. Additionally, lupus patients, sorry, I accidentally advanced it, but lupus patients also have things like arthritis, complement deficiencies, high immune complexes, and all these things we also see in PANSS patients, so that's why I bring that up. Another example is inflammatory back pain. There is a high rate of psychiatric symptoms among adults with spondyloarthritis, with 40% having depression and anxiety. And there's a higher prevalence of OCD and anger hostility among adults with spondyloarthritis compared to controls. And adults with spondyloarthritis are more likely to deliberately harm themselves. So in 2012, we decided to start a clinic to look at a spectrum of inflammatory brain diseases that can present with psychiatric symptoms. So the clinic was staffed with a rheumatologist, myself, and 2 psychiatrists. And we were thinking that we were going to be evaluating a range of inflammatory psychiatric conditions. But interestingly, the majority of patients coming to our clinic wanted a workup for PANSS or PANSS. And we actually didn't know virtually anything about PANSS and PANSS when we started this clinic. So we really had to learn a lot. And we first had a conference where we invited people out, especially to Slido, but also others at Latimer and many others, to really teach us about PANSS and PANDAS and for us to come to an understanding of how we would evaluate and diagnose. So we learned as much as we could about PANDAS and PANDAS, and we found that not every patient coming wanting to work up for PANDAS and PANS had that, but some of these patients actually have Behçet's disease, or lupus, or Sydenham's chorea. But most did indeed not meet criteria for another disease, but have PANDAS and PANS. Oh, no, I am so sorry. I don't know why my PowerPoint is crashing. I apologize, Dr. Corey.
Yeah, Jenny, that's okay. It happens to me when I give some talks. Next time, I think if you just hit OK on that little error message, it might just reopen where you started. But here, we're off again. It's good.
Okay. So, as a rheumatologist, I admit I'm not a neurologist, but I'm glad that Dr. Corey and Anna Conkey have invited Jatan Agalia and Dr. Fry, who are very good neuroscientists. We're going to talk to you more about the brain in PANSS and PANDAS. But this is my primitive understanding of the basal ganglia. So the basal ganglia exert inhibitory influence on brain functions, so primarily motor and behavior systems. And damage can result in the release of inhibitory circuits. So the basal ganglia exert control over movement, mood, emotion, behavior, procedural learning, and cognition. So it's not surprising that if you have an inflammatory disease like Sydenham's chorea, that you would have release of motor patterns and a release or a dysregulation of mood, emotion, behavior, etc. So to delve deeper into the example of Sydenham's chorea, it is one of the major clinical manifestations of acute rheumatic fever, and it's the most common form of acquired chorea in childhood. In fact, worldwide, it's the most common acquired neurological defect. It has 3 components: emotional lability, plus or minus psychiatric changes, hypotonia, and chorea, which are involuntary, brief, random, and irregular movements of the limbs and face. And the child will present as continuous restlessness. Common psychiatric symptoms include irritability, emotional lability, outbursts of inappropriate behavior, obsessive compulsive behavior, and distractibility. It sounds a lot like PANDAS and TAMS, right? Emotional changes, especially easy crying or inappropriate laughing, and obsessive compulsive symptoms are common, and they can either precede the chorea, be concurrent with the presentation of chorea, or follow the development of chorea. Here's a publication from, let's see, I think it's 1926. Oh boy, I'm sorry.
It is what it is. Now I feel like I should prepare some jokes to entertain the PowerPoint's trash.
I've never had this happen.
I can just show my fire again. It's pretty cool.
That's perfect. See, this gives people to sort of reflect on what I'm saying and have some.
I can do handstands too. I'll prepare one for the next time.
Okay, perfect.
All right, thanks.
Okay, here's some more about Sydenham's chorea. So obsessive compulsive symptoms can start 2 to 4 weeks before chorea. Chorea may be subtle or masked so that clinicians will have to actively look for the family doesn't come in look restless. And I think or hung-up reflexes. The onset of chorea can be 1 to 8 months after the strep infection. So if the ASO and DNase titers are they can be normal, right? So the titers are only elevated for a few months after a strep infection. So if you have negative titers, it doesn't mean that this is not Sydenham's chorea. Other manifestations of acute rheumatic fever include carditis and valvulitis, but you have to listen to the heart, get an echo, and get an EKG to look at the PR interval. These patients can also have migratory polyarthritis. But I promise you, in a case of a severe sort of psychiatric presentation, the last thing the parents are going to bother you about is that limping episode that occurred a couple of weeks ago. And the other interesting thing about acute rheumatic fever is 1 dose of NSAID can abort the arthritis. So instead of it being a migratory pattern, they may only have pain in a single joint for a few hours. The parents give the NSAID, and then the arthritis is gone. But you really should ask about a limping episode in the recent past, or if the kid was guarding a joint. That would be an important thing to get on history. Subcutaneous nodules are rare. We did have 1 kid with PANDAS present and had a subcutaneous nodule, and we reclassified them as Sydenham's chorea. And then I will show you a picture of this classic erythema marginatum rash. Mild cases of Sydenham's chorea without other manifestations of acute rheumatic fever may be mistakenly ascribed to behavioral or emotional disorders, Tourette syndrome, and clumsiness. And this was based on an article by Dr. Stollerman in The Lancet in 1997. So again, you really have to look for Sydenham's chorea so that you don't miss it. So this is
an example of the erythema marginatum rash that you can see with Sydenham's chorea. This was the case of a boy who was diagnosed by his 85-year-old pediatrician as having Sydenham's chorea. The child had presented mostly with emotional lability and psychiatric symptoms, and the pediatrician observed and recorded in his clinic notes a milkmaid grip. And then ultimately he was referred to an academic center that did not appreciate, maybe because the sign was gone by the time the child got there, but did not appreciate that the child had acute rheumatic fever. And this kid suffered from relapsing and remitting exacerbations of the psychiatric symptoms, and then eventually ended up in our hospital with catatonia. When we realized that the original pediatrician had observed this milkmaid grip, we wanted to investigate acute rheumatic fever, but unfortunately the kid was catatonic and could not participate in the neurological exam. So we did ultimately put warm blankets on him. We thought if this was a long-standing case of Sydenham's chorea, we might be able to bring out this rash. And sure enough, after raising his core temperature, we were able to appreciate this rash. So again, this just goes to show that you have to go look for the signs. The signs aren't always going to be there unless you're looking for them. So William Osler in the 1800s was actually the first person to describe this sudden behavior change in children who develop chorea, or the perseverativeness of behavior. So this idea of a stress-triggered, behavior, OCD, syndrome this is not a new construct. In the 1950s and 60s, there were publications about the obsessional neuroses among children with Sydenham's chorea and in adults with a history of Sydenham's chorea during childhood. The National Institute of Mental Health with Dr. Swedo also published that 75% of children with Sydenham's chorea have obsessive compulsive symptoms. And in Brazil, there's been a couple of publications describing the rates of obsessive compulsive symptoms among patients with Sydenham's chorea. So Dr. Swedo previously gave, she's given many grand rounds on PANS and PANDAS, but here's a link below at the bottom of the screen for the grand rounds that the University of Wisconsin put up on, and the Neuroimmune Foundation sponsored. So I suggest that you see her video for a more clear description of PANDAS. One thing that she always points out is that PANDAS is not a waxing and waning disorder like Tourette's, that it's relapsing and remitting. These kids have acute decompensations, presumably being triggered by group A stress, but like I described in Sydenham's chorea, sometimes the stress is remote from the deterioration. So establishing a temporal relationship can be very difficult, just like it is with Sydenham's chorea. And this is why ultimately Dr. Swedo led the effort to develop the PANS criteria, which was agnostic for the triggering infection. And just because the criteria is agnostic, it doesn't mean that we don't appreciate that stress is still a major trigger. It's just that sometimes it's really hard to show in an individual case that stress was the trigger. But there are lots of epidemiologic studies that support the construct of Sydenham's chorea and PANDAS. The most recent publication is this publication in JAMA Psychiatry, just published last year, which was a population-based study of over 1 million children living in Denmark. And this study brought out the fact that strep throat infection increases the risk of many mental disorders, but particularly OCD and tic disorders. But interestingly, it also brought out that other throat infections are associated with increased risk, but not quite as high of a risk as strep infection. So having the PANS criteria being agnostic also recognizes the fact that other infections might be causing deteriorations. Even in Sydenham's chorea, there is a belief that after the development of Sydenham's chorea, viral infections can trigger relapses. Here's a beautiful study by Dr. Tanya Murphy, who showed that group A strep infections can correlate with abnormal movements and hyperactivity. And again, this is not pandas, this is not Sydenham's chorea. These are healthy children that have this association between a positive throat swab and adventitious movements. And what she did was there is a school district in Florida where they still do screening for strep throat. And she and her colleagues watched 693 children who are in line for a throat swab. So essentially they were blinded raters. They did not know whether the kid would turn out positive or negative. And they observed the presence of tics, abnormal movements, and problem behaviors in line. And they showed that there was a correlation between having a positive strep throat and these abnormal movements. And they also showed that recurrence of a group A strep infection increases the risk further. So again, this is a study that supports the construct of Sydenham's chorea and pandas. Sorry, it crashed again.
All right, I'm back. So during this little intermission, because of Dr. Frankovich's PowerPoint keeps crashing, I'm supposed to entertain you. I got nothing right now. I'm just doing like filler voices here, Jenny. Jenny, could you bring yourself back online here? Because I'm dying.
Yeah, no, I don't know where it's coming. I'm sure it's coming.
No, that's all right. That's all right. Well, anyway, I'm listening to, I'm hanging on every word, so I really appreciate the information so far. You know, sometimes, no, you don't have a lot of programs open, so I don't know why it keeps crashing.
Yeah.
You know, a solution that I've done, I don't think I'm going to recommend it now, but I generally restart my computer, but that would take a fair amount of time. You were on a stretch for a while.
I was.
A 10-minute clip, so is it opening now?
Well, you know what I think happened is somehow the PowerPoint decided it was going to update the program while I was doing it. So I think...
Brilliant.
Yeah. Let those automatic updates.
You know, I was, I don't want you to multitask. I was thinking about maybe firing a question at you while you're struggling.
You can fire a question at me.
Well, they're kind of
that's what we do in clinic, right?
Yeah, this is true. You're always trying to balance, spin a few plates, but some of them are kind of high level right now. I was gonna, maybe I should wait for one for the end.
Let me see if Jackie can pull it up on her computer. I don't know if that would.
That might actually work better. Wow, I have a totally random question. It's not a judgment on the question. It's just one that I had never heard before. Can I share it with you?
Yeah.
Or are you busy? All right, this is just from the list. Have you had any experience with fecal transplant for gut repair in children with pandas?
I've had one patient whose family actually consulted with some physicians at Harvard, believe it or not, because I know they don't believe in pans and pandas, but and it was actually a researcher had recommended that they try it, and they did, and actually it's hard to know what sort of led to that child going into remission, because the child also received IVIG, NSAIDs, and antibiotics. But that child did go into a long-lasting remission, and that was 4 years ago, and as far as I know, the child is still in a remission and I think heading off to college and doing fantastic. So that is my one anecdotal sort of experience with it, but again, the child received a number of treatments, so it's hard to know, what exactly led to the improvement.
Hey, Jenny, I have a suggestion real quick. If Jackie could load the talk on her computer, I can make her a panelist, and you'll you'll finish the talk under her name.
Okay, you know what? I have the PowerPoint up again.
Okay.
So now I just need to share.
Yeah, if you go down to the bottom where it says share.
Yeah. Okay. Here it is.
Yay. Yep. Okay. Just make it yeah, that's it. You're good. I'm gonna drop out.
Sorry about that, everyone. So here's a great study done by Dr. Geed and Dr. Sweeto. Maybe you all have seen this already, but really showing the volumetric differences in the different structures of the basal ganglia in controls compared to patients. Sorry, I moved my mouse and it advanced it, so I can't say. But anyways, that study by Dr. Geed did show that the patients with PANDAS had larger basal ganglia structures. And this is another wonderful study by Dr. Chugani, where he used a tracer which binds to a receptor that is expressed on activated microglial cells, and he showed there was increased binding potential in the basal ganglia structures of PANDAS patients compared to controls. But he also found this in TRESS patients, that the PANDAS patients involved not only the caudate, but also the lentiform nuclei. So the PANDS criteria, as I mentioned, were developed to be agnostic to the strep trigger, and in order to not overlap with the research that good neurologists are doing in Tourette's, they really focused on the psychiatric components, which are OCD and eating restriction. And although the criteria require 2 comorbid symptoms, most of the published studies are actually showing that when a kid presents with abrupt onset OCD to PANS centers, that most of those kids have many of these criteria. And on average, our patients meet 5 of these criteria. In our cohort, the mean age of first symptom onset is about 8.8 years, but the mean presentation to our clinic is 10.8 years. When we first started our clinic, we took all comers, and some of these kids had PANDAS and PANS for many years. We are now only taking new onset kids, so our statistics are skewed by who we're actually accepting into clinic. Most of our patients fall into this relapsing and remitting category, and that makes sense because we think this is an infection-triggered neuropsychiatric deterioration. So this is like many autoimmune and rheumatologic diseases, including multiple sclerosis and lupus, where you can achieve a remission, but you're at risk for having another deterioration. So one of the major research goals we have is, what is a good maintenance regimen? How can we prevent the relapses? The sleep abnormalities in these kids can be quite prominent, and they're now showing that many autoimmune disorders are associated with sleep interference. The most interesting sleep abnormality is this thing called REM motor disinhibition. This is where, so REM sleep is where you're supposed to be paralyzed, so it's during dreams. So you're not supposed to be acting out your dreams, but these children, up to 60% of them, actually move during REM sleep. And this is highly abnormal. I mean, we don't really know what this means in kids, but in adults, it's a predictor of Parkinson's disease, multiple systems atrophy, and cognitive impairment. So this is not sort of a made-up disorder. This is not something that kids can fake. You really are paralyzed during REM sleep. So I feel like this is a solid organic finding that we should be assessing more in our kids that present with PANDAS, and this has not been looked at in Hands Korea, but it's something that we should probably do. And I want to, just in case there are families on the line, I'm not, just because this has been associated with Parkinson's disease in adults, it doesn't mean that your child is going to have that. We don't know what this finding means in childhood. We do see a high rate of concurrent arthritis among patients with PANS. So this is about 148 patients. So this is not all the patients that have come to our clinic. This is just our local community cohort of PANS. So a lot of the studies we're publishing as what does our community cohort look like? Because as you can imagine, if people travel a long way to come see us, as what happened when we first opened the clinic, their disease may be more severe, and that's why they've come so far. So we really wanted to describe what are we seeing in just a community cohort of patients. And so this is what we're seeing. We're actually seeing a high rate of inflammatory musculoskeletal conditions, with the most common being something called enthesitis-related arthritis, so where tendons and ligaments insert onto bones. And I'm fairly certain the children are not studying the rheumatology textbook, and I don't think they know where the emphases are, but it is very interesting that 22% of our patients actually have pain at these sites. We also see that 16% of patients meet criteria for spondyloarthritis, 6% have transient or reactive arthritis, and 5% have psoriatic arthritis. So these numbers don't add up to 39% because some of these patients met criteria for both, and we use standard rheumatology definitions for classification of these disorders. So not all of our kids that came in with joint pain met criteria for one of these diseases. We tried to be conservative with our estimates, but it's still a very high percentage. We also see that there's a high rate of development of other autoimmune diseases, so beyond the arthritis in our community cohort. So including autoimmune thyroiditis, celiac disease, chronic urticaria requiring steroids, antiphospholipid antibody, and type 1 diabetes. Sorry.
Hi, Jenny.
Hello. I don't know what's happening.
It's wanting to freeze. So I have, I asked Jackie to maybe load it up on her computer, and maybe we could just switch computers real quick.
Yeah, Jackie is unfortunately gone.
No,
you're not. Oh, shoot.
Sure. I told her to stick around in case we ran into trouble.
Oh, okay. Thanks, Jackie.
So, Jackie, I'm going to make you a panelist. Jackie, are you signed into the webinar?
I will be in 20 seconds.
Okay. So, to all the hundreds of participants or attendees out there, sorry about the technical glitches. We're human. These are computers. We are doing the dance.
And I am located in Silicon Valley, so we do have a higher rate of technical difficulties here.
It's not reassuring, Jenny. I mean, technological problems should not be synonymous. But anyway, I just wanted to put a shout out that we have over 200 participants.
Oh, it's going now.
Big audience. Okay, guys, we're back on.
That's bizarre. I don't know. It just suddenly started working, but it advanced a lot. Okay, so back to the autoimmune disease. So this is the time-dependent risk of developing an autoimmune disease in addition to PANS amongst our local cohort. So as you can see, most of the autoimmune diseases followed the PANS onset, which I think is interesting because maybe the brain is sensing inflammation even before we appreciate that the child has is developing other autoimmunity. So I think this should be of great importance to scientists who are trying to study autoimmune diseases in the early phases. And this is not surprising based on epidemiologic studies. So this is a recent study just last year that showed that there's a clustering of autoimmune diseases in families with OCD, Tourette's, and chronic tic disorder. So again, an epidemiologic study that supports this concept that obsessive compulsive disorder may be linked to autoimmune disease. So in addition to inflammatory joint pain, we also see more pain syndromes in these children. And again, these children are not making up their pain. This is very real pain, but we think that pain is processed in the basal ganglia, possibly even the thalamus. And if there's disruption, this is, could be contributing to why some of these patients have more pain. The risk of a pain amplification syndrome is highest around the time of PANS onset, but usually the psychiatric symptoms and the mental anguish is so severe, the families are not bringing up pain. So we have a standardized questionnaire we give to our families and we track pain. And as OCD and psychiatric symptoms get better, then these kids do start talking about their pain. Headaches and abdominal pain is common. Some develop this thing called CRPS, which is a regional pain syndrome, or these patients have widespread pain. 15% of our patients met criteria for fibromyalgia. And now that we know that pain is very common in this PANS cohort, we actually, this is part of our education. So we teach the families to sort of recognize the pain, and that the best way to deal with the pain is actually, well, when it's headaches and abdominal pain, that's challenging. But when it's limb pain, if you move the limb, it actually helps the child to overcome the pain. So instead of immobilizing painful joints, we actually move painful parts of the body. And this has really helped us get kids into a pain remission early. We also use medications like amitriptyline and gabapentin, which are sort of standard approaches to pediatric pain. Like many people with pain syndromes and fibromyalgia, we've also found that kids have fatigue. Again, we usually see the fatigue becoming more profound after sort of a lot of the psychiatric symptoms start improving. These statistics are based on a fibromyalgia questionnaire that our patients fill out. So as a clinician, you know, I think it's easy to sort of dismiss these kids as saying, oh my gosh, you had all those psychiatric symptoms, now you have pain symptoms, now you have fatigue, like how could you have all those problems? Well, they're all linked together, and it's probably the brain. And I think that, you know, we're showing a big overlap between these conditions amongst our patients, and again, these children, these families are not making it up. These are real symptoms, and these patients are suffering. So because of the particular inflammatory sort of symptoms that we are observing in these patients, primarily the type of musculoskeletal inflammatory symptoms, we decided to look at the HLA-B region. And when we found that there was an overrepresentation of certain HLA types, we decided to collaborate with Marcelo Fernandez, who's a very good sort of HLA scientist, in sequencing the whole HLA region of these kids, of our cohort. And then we had Jill Hollenbach, who's a neuroimmunogeneticist at UCSF. She analyzed our data. So initially she found that the B38, the B52 were overrepresented in our patients compared to the NIH Indigo control cohort. She did not confirm our original finding of B55. No, it stopped again.
I think Jackie's around.
Great.
Jackie, you there to save the day?
Yeah, I'm here.
Okay.
Want me to pull mine off? Okay, right here. Right here.
And are you an attendee right now, Jackie?
Yeah, I am.
All right, I'm going to try to find your name on the 200 patients.
I just raised my hand.
And I will make you a, I don't see you as an attendee. Are you signed in?
Yes.
Oh, it's working. Do you see me? Do you see it again or no?
You have to share your PowerPoint. Is this your computer, Jenny?
Yeah. Okay. We'll just work on yours. So you see Jackie?
Not right now. I'm trying to find her. Jackie, could you use the link that I'd given you? It'll make you a panelist. Oh, wait, here you go. I'm going to make you a panelist right now, and then you'll be good. Yes. Now, Dr. Frankovich, you're getting fired.
Okay.
So you're no longer going to be a panelist under your name. So all the attendees watching, Dr. Frankovich will be presenting under the name Jacqueline Horgan. And now, Dr. Frankovich, all you have to, or Jackie, please share your screen and the audio. Are you guys making noise? Oh, no, you're not sharing your, okay, you're unmuted now. And now we have your screen. I can see the video and I can see the desktop. Just make your PowerPoint into a slideshow.
Can you slide it? Make this into slide?
Go up to slideshow on the menu at the top.
Okay.
And just put, yeah, there you go, you're there. And play from whatever slide you guys want to, and then maybe.
Slideshow.
I would just go from play from current, yeah, there you go.
Okay.
You're in a presenter view now. You want to just go to slideshow. So up at the top here, use slideshow. Yeah, it's better for this format. Yes, perfect.
Oh, I want to.
Okay, I'm out.
Oh my God, you're just looking at something. So this is a review for everyone.
So mute yours.
Okay. Okay, so to make a long story short, we did see an association between HLA-B27, not surprising, that is associated with inflammatory back pain. So the fact that we see a high rate of inflammatory back pain in our patients is not surprising, and that there are, OCD, anger, hostility issues in patients with inflammatory back pain. So all of this is making sense based on the genetics. And then interestingly, when you take all three of those alleles that are associated with PAMs, they have one thing in common, and that is they have sort of an amino acid change in position 80 that is strongly associated with PAMs. And this is relevant because dimorphism at position 80 refines the binding affinity of a receptor on NK cells, or natural killer cells. So this is the KIR binding site. This is where we think that there's a relevant amino acid change. This is preliminary data. We are trying to confirm this finding in another cohort, actually Dr. Sweeto's cohort, to see if this finding holds true in her patient population. And if that's true, then we're going to sequence KIR. And then if that is still relevant, then we will start looking at NK cells as a possible contributor to this illness, and that could open up other treatment opportunities. So if we believe that PAMS is an inflammatory disorder, then we would expect to see some blood dyscrasia. So most inflammatory diseases, rheumatologic diseases, are associated with changes in blood counts. So we actually applied the definitions of blood dyscrasias that we see in lupus patients, leukopenia, lymphopenia, thrombocytopenia, and found that we definitely are seeing this in our PAMS cohort. Some patients come in with thrombocytosis and then these other sort of findings of anemia, maybe anemia of chronic disease. We're still trying to sort that out. We also see a high rate, we think is a high rate of other autoimmune markers. These are probably all non-specific markers, but again, going along with this hypothesis that this disease involves autoimmunity and inflammation. And like lupus patients, we also see high C1q binding assay, low C4, and elevated C4a levels. I would caution you though, C4a, the test that we used was the one that is done at National Jewish, and although they do a very good assay, there's a lot of handling issues and sensitivities, and if the specimen sits out too long, you can have a falsely elevated C4a. We really trained our phlebotomists and our team to do this correctly, but occasionally we would have a falsely elevated C4a. So I think if you're out in the community and you don't have the time and ability to really train your people how to handle the specimen, this test should not be evaluated by sort of the community, since it is not a reliable test. But we did say, at least in our institution and the way we were doing it, the C4a levels did correlate with global impairment scores in our patients with PAMS. We did validate the global impairment score in our cohort of PAMS patients. It's not a great measure of impairment, but it was the best we had. And again, C4a levels have problems. So the fact we found any statistical significance is interesting, but again, this shouldn't be used in the community. We also see signs of vasculitis. So that BW4 gene that we found, in addition to being associated with inflammatory back pain, it's actually also associated with Behçet's disease, which you might remember from one of my first slides, is another inflammatory disease that can cause psychiatric symptoms. And Behçet's patients have a lot of, so it's actually a vasculitis. So the fact that we're finding some subtle signs of vasculitis in our patients is not surprising. We also see some lab markers of, that suggest vascular inflammation, including von Willebrand's factor antigen and high D dimers. Here's some examples. So in the first slide, we see this is periungual redness, and we think that's sort of inflamed blood vessels. We see palatal petechiae, which actually is 95% specific for group A strep, but most of these patients that we screened did not have active strep at the time of their presentation with the palatal petechiae. So this may just represent sort of inflamed blood vessels, but we missed the opportunity to check the group A strep, or there might be some other organism that's triggering this illness and triggering this vasculitis, or small vessel inflammation. This is called Terry's nails, and again, this is inflammation in blood vessels. We usually only see this in those handful of very chronic cases that we've seen, but sometimes we appreciate it more subtly in patients that aren't so chronic. And then livedo reticularis, also possibly a sign of blood vessel inflammation, seems to be more common in our patients with chronic disease. So we also see a higher rate of primary immune deficiency compared to the general pediatric population. So even though this rate is much higher than the general pediatric population, it still constitutes a small proportion of our patients in our PANSS clinic. So only, less than 4% of our whole cohort has an identified primary immune deficiency. And all of these patients had recurrent sinopulmonary infections from a very young age. So we don't screen all of our patients for primary immune deficiency, just kids with recurrent sinopulmonary disease. But it's interesting that we do see this in our patient population, because we know that primary immune deficiencies do predispose to autoimmune diseases. And in our cohort, the patients that had both PANSS and primary immune deficiency, they have the highest rates of additional autoimmune diseases. So in terms of the clinical management of PANSS, I'd like to refer you to this journal where we published what we thought was the best approach to managing PANSS. And of course, this is controversial because, well, I'm sure everyone on here probably knows, but it's really just common sense. It's how you would approach Sydenham's chorea. It's how you would approach a lot of diseases. Examine the patient. If the patient has an active infection, you should treat that active infection. Don't treat infections that aren't there, and don't try to make up infections, but if they have it, do. If they meet criteria for Sydenham's chorea, or it's, an awfully close mix, then you could consider prophylaxing them with penicillin. But the second point, the second pillar of treatment is really to treat the post-infectious inflammation. And for this, we're using and we're studying corticosteroid bursts and NSAIDs. And I think that there's a lot of work that needs to be done in looking at other things that could help treat and calm this post-infectious inflammation. But the third pillar is treating the psychiatric symptoms. Just like if a kid comes in with arthritis, the kid is going to need physical therapy, right? If a patient has a stroke, doesn't matter what caused the stroke, the patient is going to need rehabilitation. All patients coming in with PANSS and PANDAS, they've had, we think, injury in their brain. Injury can be overcome, but it can only be overcome with rehabilitation. And if there are injured neurons, which Dr. Dratan Aghalia's animal models was really suggesting that there is some neuronal inflammation and damage, that these kids are probably would benefit, and actually we've seen in our clinic, these kids really do benefit from standard approach to their psychiatric symptoms, especially SSRIs. Now, of course, if they're in the acute inflammatory phase, these medicines may backfire. But after the infection and inflammation is getting better, we find that these medications can be very helpful. So please, if you're a clinician, please pay attention to the third pillar and treat the psychiatric symptoms. It's of course on blogs, the parents are going to tell you the worst stories. And there are cases, including in our clinic, where a kid got worse on an SSRI. But if a kid gets worse on an SSRI during one phase of the illness, it does not mean they won't benefit from that in another phase of illness. So please, readdress these questions in patients who had, illness for a long period of time. So here's some of our data. So we looked at the effect of oral steroids on the first episode of PANS. So in general, the first episode lasts on average 16 weeks. And when treated with an oral steroid burst, the duration of that episode was less. And we published this, and you can see we had to do a sort of multivariate model to account for a lot of confounding variables. But here's all of our patients with relapsing and remitting, and again, this is the use of an oral corticosteroid burst early in the flare. And so when you take all of the flares of PANS, they last on average 11 weeks, but we could get it down to 6 weeks. And then patients, if they're treated with NSAIDs within the first 10 days of their flare, we can see in a decreased duration of their PANS flare. But there was no difference between patients who stayed on NSAIDs versus those who came off of it. But this data is confounded by the fact that the kids that stayed on the NSAIDs were probably the kids with arthritis, or were kids that every time the parent took them off the NSAIDs, they got worse. So some of this is confounding. We're really not going to know whether steroids and NSAIDs work until we do the randomized placebo-controlled trial. So as part of our program, we are working very hard, and our families and the patients have been wonderful at giving blood specimens during flares and remissions, and also helping us to recruit healthy controls. And we're sharing these specimens with many scientists. We have a lot of Stanford research scientists helping us. In particular, Betsy Mellons is studying brain monocytes. There's a postdoc in Larry Steinman's lab who's looking at proteomics. My boss, Dave Lewis, the head of immunology, is looking at T and B cell phenotyping. We're also doing phosphocytoph. Mark Davis, his postdoc is looking at T-cell receptor repertoires. We're doing some exome sequencing, and then, as I mentioned, the HLA sequencing. And Margaret Tienemann, who's the director of psychiatry in the PANS clinic, is also doing some wonderful work looking at neuropsychiatric testing and parent therapy groups. And also looking at response to psychiatric medicine. So we're looking forward to learning more from what Margot has to share with us. We also have external collaborators, including Chris Pittenger at Yale. And we're collaborating with Arizona and Wisconsin and Columbia on an IVIG trial. And we have some interesting upcoming collaborations, including using direct current stimulation in patients with chronic OCD, among those treated with PANS, and some MRI study collaborations. So really, we have a lot of things that we have to accomplish here. I know there's a lot of families and patients out there that are dealing with chronic symptoms, and that definitely should be a goal. I know right now our funding has really revolved around nuanced cases and what's causing this, but I really hope to increase our funding and our capacity so that we can either create trials or create strategies to help treat these chronic cases, because we have had some chronic cases turn around, and we all want to help all those kids out there that are still suffering so much And then, as I mentioned earlier, it definitely needs to be a goal of all of the academic centers to come up with ways to prevent relapses, because we know with every relapse, things can get worse and more difficult to treat. I wanted to close with an example of this 8-year-old boy who had a very abrupt personality change. This was a kid that was happy and boisterous and social that suddenly overnight developed anhedonia. And, you know, this is a rare situation where he got an MRI within the first few days of this change in his personality. And the findings here really show inflammation in the basal ganglia. The neuroradiologist read this as, this looks just like Sydenham's chorea. But the kid did not meet criteria for Sydenham's chorea. He was evaluated by neurology. He didn't have chorea. But the pediatrician and the neurologist were very thoughtful. They said, you know what, this kid doesn't meet criteria for any disease, but this brain MRI looks like Sydenham's chorea. Let's do a throat swab. And it turned out the kid didn't complain of a sore throat, but he had a red pharynx. It looked like he had strep pharyngitis. And then he turned out to be positive, and then he subsequently developed sinusitis. So they treated the strep throat, they treated the sinusitis, they ultimately put him on penicillin, and he had an excellent recovery, and his MRI 6 months later was normal. So this is the only reason I bring this up, and I'm sure we couldn't even get this case published because, you know, the reviewers were basically saying, well, he doesn't meet criteria, and, you know, each of the reviewers had a different sort of spin on the case, and it doesn't matter what the criteria is. You really have to treat the patient, and you know, I just want to bring this up because I don't want us to get hung up on labels and arguing over labels. We really just have to treat the patient to the best of our knowledge. And I hope that someday we'll have better biological markers and blood tests to help clinicians diagnose these cases, because it is very difficult as a clinician to make these hard calls about antibiotics and anti-inflammatories without, you know, sort of having solid tests reconfirming. But in the old days, we didn't have lab tests, and we still treated the patient. So I hope until we can get better blood tests, that clinicians will do how we would practice medicine how we did in the past when we didn't have enough evidence. We don't have enough evidence right now, but we do have our physical exams that you can rely on, and I hope that a lot of these families have a good relationship with their pediatricians, so that the pediatrician can trust that the child's course of illness suggests that there was an acute deterioration. So evidence that PANS and PANDAS is an inflammatory disorder. So imaging data that shows swelling and increased microglial activation by Drs. Deed and Chugani. This strong association we see with HLA-BW4, which is associated with other inflammatory diseases like Behçet's disease, spondyloarthritis, Takayasu's disease. This is preliminary data, and we hope to give you some more details about this coming up. And then the signs of systemic inflammation that we see in these patients with PANS and PANDAS, including high rates of autoimmune diseases, autoantibodies, inflammatory musculoskeletal symptoms, complement activation, like what you see in lupus, vasculitis markers, like what you see in Behçet's disease. These are all signs that we see in other accepted inflammatory brain disorders. So look for these signs in your patients, whether or not you agree with PANS or PANDAS, look for the signs. And then we have preliminary data that suggests patients respond to immunomodulatory therapy, but of course, nothing is really proven until you have a randomized placebo-controlled trial. Those trials are extremely expensive, and of course, you know, it's hard to raise money for controversial diagnoses and unclear diagnoses. But we need to do this, and I think that if we can find biomarkers, then it will help us design trials better. And then thanks to all the basic scientists that are really helping us to study this disease, including Dr. Agalia in Columbia and all of the wonderful scientists at Stanford who are finding some very interesting immunologic data that differentiates these children from healthy controls and hopefully will give us insights into new treatments. And then I wanted to thank the funders of our research in our research program, including Stanford Spark, the Stanford Children's Research Fund, the PANS and PANDAS Physician Network, and the NIMH Developmental Pediatrics Branch, Pray Kids, and all the grateful donors and community foundations and other fundraising efforts that have helped us. And then I also wanted to thank the wonderful physicians in our clinic, including Dr. Willett, who is now the medical director of our clinic, and Margot Tienemann, who's a child psychiatrist and a world expert in OCD. She's been treating OCD for 3 decades. Melissa Silverman and Paula Tran are former chief residents at Stanford Child Psychiatry, and they've just joined our clinic. We have an allergy immunologist, Joseph Hernandez, 2 wonderful nurse practitioners, Bahari and Allison, Joanne, who's our patient care coordinator and keeps us running, and then we've recently hired an epidemiologist, Avis Chan, Janelle Gao, and Lori Colombo. And I forgot, there's one more, Cindy Mako, who's our clinic research assistant. So thanks to our whole staff for helping us see these patients and gather research data. And then this is the PANS Research Consortium that was founded in 2012 at the conference where we created the evaluation guidelines. And we really needed each other during the early days of this because we were all, not knowing exactly how to treat these patients, but we've worked together, and it's a great group of dedicated clinicians and scientists. And some take-home points are that these post-infectious inflammatory disorders affecting the brain can cause psychiatric symptoms in children and can present abruptly. In addition to psychiatric symptoms, patients often have new onset behavior disturbances, motor signs that you have to look for, sensory and sleep disturbances, urinary symptoms, and cognitive symptoms. And there is direct and indirect evidence that these conditions are mediated by inflammation. So I'm ready for questions.
All right. So, Dr. Frankovich, thank you so much for that presentation. I mean, you covered a lot of areas. We have some questions coming in, and I'm trying to put them together. I don't want to monopolize this, but I do want to make one point.
Okay.
That last slide with the MRI of that kid, and then your comments after that, I just want to tell you how much that hits home, and it really illustrates the challenging point is that we all want a good clinical test to tell us what's going on. There just isn't a great one right now, and I got to tell you, although historically all physicians made clinical diagnoses, it seems like that's a thing of the past. My favorite little factoid today was about Osler and how Osler recognized that association over 100 years ago, and that was just an astute observer clinician, and it's unfortunate that we don't have as many Oslers around. And so if we did, I think it wouldn't be as much trouble. That would be one comment. The other is, and I'm going to ask this question, pandas is fake news in the U.S. Is there any other country in which it's fake news?
I would say that it's controversial, I mean, for sure in Europe, and I think that it is controversial all over the world. I do think in third world countries, though, they recognize Sydenham's chorea much better than we do. So I think in Brazil, in fact, there was, I think it was an article from Brazil and even one from South Africa where they describe that in their rating scales of Sydenham's chorea, in the write-up, they actually say that they think that Sydenham's chorea is being mislabeled as PANDAS. And it doesn't matter, like in the end, these things are probably on a spectrum.
Right.
So I wish there was a way we could just, sort of call it all one thing and have a test. But right now they are 2 distinct entities. Hopefully
we get it there. So I'm just going to start out with some straightforward questions, and then I'll try to go a little bit higher in complexity. So one is, how significant is toe walking as a symptom? There's one Dr. McGrew who comments that she's had several kids in her practice who do a lot of toe walking.
Yeah, so I did have at least one patient that had toe walking with at least 1 or 2 of their episodes. I don't think it's that common. We do have all of our patients do some walking evaluations. And so, again, I only had one patient that I recall, but it's, but it may be associated. I don't know.
Okay. Mm-hmm. And then 2 sort of questions which I'll combine on Lyme disease. So one is an attendee asked, if the ASO and lupus markers are negative, but they're CDC Lyme positive, could that be associated with or cause PANS? Lyme disease. And then the second question is, how often is Lyme's implicated in PANS?
Right.
They're related questions, so I'll put them
It
together.
probably depends on where you live, right? If you live in Arizona and there's no deer ticks, and you've never been outside of Arizona, then I could say that the incidence is probably 0. If you live in Maine or, you know, the Northeast, then I think it's possible that Lyme disease triggers. Actually, we had a couple of cases in really one case that it was absolutely clear that a kid was diagnosed by Mark Pasternak as having disseminated Lyme, and she did develop PANS. So, I mean, this idea that strep is an infection that triggers inflammation in the brain, I would not be surprised if Lyme triggers inflammation. In fact, the animal models of Lyme show that the Lyme spirochete does not itself, at least in animal models, it does not cause changes to the neurons, but really it causes a reactive inflammation, and it's the inflammation that's causing the neuropsychiatric symptoms in the animals. So again, even like with the Lyme triggered arthritis, it's, you know, in some cases it's the Lyme in the joint, but if you're HLA, I think DR4, there's a particular HLA type that you actually develop a reactive inflammation to the Lyme, but then you have to treat the inflammation, not the Lyme. So I think that it becomes tricky. I think a lot of, especially sort of Lyme savvy doctors, keep trying to treat the Lyme, but we have to remember that the Lyme may come and go, just like strep comes and goes. You still have to treat the inflammatory component.
Okay, and this is a really good question. So someone asked, how can you diagnose PANS in a sort of a neuroatypical, sort of severe autistic, maybe nonverbal child?
Right. That is very difficult. And I think there are people like Dr. Fry, I don't remember the other clinicians off the top of my head, but I know that there are people that are intently studying autism and the link to inflammation, especially with regards to these deteriorations that autism kids can have. I know that there are sort of neurometabolic endocrine things that can change in a kid with autism, but it's not inconceivable that a kid with autism could develop a strep infection and have a neuropsychiatric deterioration from that. But I think that question it is a very good question, and again, just emphasizes the need for a biological blood marker, some type of marker to diagnose this. But I think until we have that, relying on autism experts like Dr. Fry to aid in that diagnosis, and maybe even just understanding the trajectory of the illness. I mean, if the kid is at a stable baseline and they suddenly deteriorate, that definitely would give cause to working up an inflammatory brain condition.
Great, thank you. That's helpful. Here's one. So do you order B and T cell panels on patients prior to treatment? And have you noticed elevations in CD3, 4, 8, 19 in children with PANS?
So there have been cases where we do order T and B cell panels, especially if we are suspicious for an early immunodeficiency syndrome. But so far we haven't seen a pattern. I mean, we have some kids with high CD19 counts, we have some kids with low CD19 counts. So I think that so far the T and B cell subset panel has not been helpful in guiding our decision.
Okay, so that basically elevations in any one of those does not really predict treatment response.
No, because it's so state dependent. If the kid happened to have a virus at the time of drawing the blood, it's just, there's not, I think that it's not helpful clinically.
Okay. No,
if the kid has an immune deficiency and there's a clinician that's working up the immune deficiency, then B-cell phenotyping panels can pick up on early chronic variable immune deficiency. But again, that should be a very small subset of kids with PANS that need that workup.
Okay. And then a second question, roughly what percentage of children in your clinic require use of rituximab for the inflammation treatment arm? And is it ever used in the absence of clear inflammatory markers in a child who otherwise meets criteria for PANS and is not responding to other treatments?
So no, in our clinic, we have not used it unless there's sort of clear indicators of an autoimmune inflammatory disease.
Okay.
We've treated the minority of patients with it. I mean, I think we've only treated maybe 15, 16 kids with it.
With rituximab?
Yeah, and in the early, I mean, we're starting to treat more. In the early days of using it, we realized that these kids were relapsing 3 months after the rituximab. And so we really were sort of losing hope that it would work, even though they initially seemed to respond, then they would start to relapse. But after we met with Genentech and some scientists, it appears that at least in animal models, these cells start repopulating around 3 to 4 months after rituximab. So we started dosing, and actually this happens with nephrotic syndrome too, where the kids start breaking through at 3 to 4 months. So we started dosing rituximab on a quarterly schedule, and it definitely seems like those kids are doing better that are on the quarterly schedule. But this is part of why we also really wanted to look at the innate immune system, because even kids that appear to be on a very good regimen of rituximab, they still have breakthrough flares. And it is almost always in the setting of a clear infection. And this kind of goes back to Betsy Mellon's work, where she's studying the monocytes, where monocytes are very sort of the first to the scene when there's an infection. So I suspect the future of PANS management might also involve controlling the innate immune system. So we've started looking at other things to use in addition to rituximab or use instead of rituximab that really we think might be calming the immune system and not allowing it to get so reactive after infections. But a lot of work needs to be done in this area.
And this is a little bit more general question. Just if you could maybe make some comments on your use of IVIG, maybe similar to rituximab, which is to say, what percentage of the time are you using it? And, how many treatments how often or frequently do you use it, or is it dependent on the patient?
It really depends on the patient, and unfortunately, there's just not enough data out there to draw conclusions. So when we first started our clinic, since we didn't really know much about PANS and PANDAS, we followed that original Lancet article, which was the randomized placebo-controlled study that Dr. Sweeto did, that suggested that IVIG was helpful. So we did treat a lot of our early patients with IVIG, but many of those patients, were chronic, and they didn't have a great response. We do think that IVIG could be more helpful in the new onset cases. We did have some chronic kids, especially one in particular that I think had Sinham's chorea, that even though they had long-standing symptoms, they still had a clear improvement in symptoms documented by our psychiatrist after introduction of IVIG. But we had had so many patients not respond or temporarily respond or just have a minor improvement. I would say that, if you don't have a good response by the second IVIG, it's not worth continuing. But yes, there's not enough data on there, and I hate to make too many conclusions about it, but this is why we are very eager to be involved in the clinical trial that Arizona, Wisconsin, and Columbia are doing.
Great. No, thank you for that answer. So I guess it's seemingly more helpful in early onset, recent diagnoses rather than the chronic children, and also you can pretty much very quickly tell whether it's working or not and whether you should persist with it.
I mean, that's my sense, but I could be wrong. Yeah.
You're the one who would know more than most.
The more I study this, the more I realize I don't know. And so yes, I think you should take all of this as just real preliminary information.
Okay. No, that's helpful. Here's another one. I'm just going to keep firing until you show a sign that you're dying over there, because
I have Jackie's computer, so she may decide she just wants her computer back.
She can't go home until someone goes with the computer.
She loves being here. She can't work. She's hostage.
So I have another question. She was writing, how do you pulse or use your steroids for this disease? She writes, I have children who do well on steroids, but we then have huge relapse when we wean off.
Yes, right. It's amazing how well kids respond to steroids. And if they don't respond to oral steroids, and we bump it up to IV steroids using the same protocols that are used in lupus, we can, I mean, it's rare that IV steroids fail. I mean, more often than not, we're not able to give it to the kid because we can't ensure their safety. But for the most part, when we're able to give it, we see dramatic improvements. But just like the person who wrote in, unless you have a maintenance therapy, kids often relapse as the steroids wear off. And that makes perfect sense. That's how it is with all the rheumatologic diseases, Behçet's disease, lupus, I mean, you name it. If there's a systemic inflammatory disease that involves the brain, it responds to steroids, but you need a maintenance medicine. So what is the right maintenance medicine is the big question. I mean, people are using rituximab, CellCept. We've had mixed results with CellCept, which is mycophenolate. We've had, I feel like, better success with methotrexate, but again, we're not going to really know until we do those randomized trials. Okay. So right now we try to use the markers of the patient. If the patient has a lot of lupus markers, low complements, lymphopenia, especially if they meet 3 lupus criteria, we tend to use more lupus drugs. If the patient has psoriasis or psoriatic arthritis, or signs of Behçet's disease, pathogy, recurrent mouth sores, then we'll use drugs more used in those diseases. So we're really using clues from the patient, treating the patient based on their own biology until we have better data.
Okay. And I'm trying to look at some of these. Do you find the Cunningham panel useful in guiding treatment or confirmation of pandas? Dr. Cunningham is a fantastic scientist, and all of the research she's published has been phenomenal. But there was a recent study in Sweden that suggests that the panel does not distinguish between healthy controls and PANS patients. So we can't use it for the diagnosis of PANS, at least not yet. I think there needs to be more studies, and we are collaborating with Dr. Cunningham. So we're not using it as a diagnostic tool, especially since we're taking very clear cases where the kids have, a normal baseline, and then overnight they develop all the PANS symptoms. So for us, it's a clinical diagnosis, and there's really nothing else that looks like it in the patient population that we're tracking. So we don't need the Cunningham panel to make that confirmation. But I do hope more work goes into the Cunningham panel and other biological markers. And I should have thanked Dr. Cunningham for her collaboration on my slide. And I just realized I left her off, but I think she is a very good scientist, and more work needs to be done on the antibodies that she's published on. Okay. And then since there was a number of questions on this particular issue, I'm going to try to combine them. So what is your opinion on the long-term use of antibiotics in these kids in order to suppress a relapse or keep them in remission? And then a second part to that is, how do you address issues of the gut microbiome in cases where they're on a lot of antibiotics or long-term antibiotics, and in particular, any dietary recommendations?
Yeah. Those are great questions, and we've struggled in individual cases, but in general, our approach has been if the kid has an immune deficiency or clearly has recurrent sinusitis, really trying to prevent sinus infections, and for the most part, that includes, good allergy treatment, and, Dr. Willett is the sort of queen of trying to prevent sinusitis relapses in our patients. But in the cases that have immune deficiencies, sometimes we've used prophylactic antibiotics to prevent that particular issue. But those, again, are the minority of cases. And good allergy treatment is usually the best approach to preventing sinusitis. In kids that have a strong suspicion that strep is their trigger, and I would say this is probably a larger proportion of our kids. So family history of acute rheumatic fever or Sydenham's chorea, clear deteriorations either psychiatric deteriorations, chorea, milkmaid grip, or even arthritis after strep infections. Those kids we keep on penicillin prophylaxis. Even in families, so in our clinic, and I know this, our clinic structure is very different than other PANS clinics, but since we're really, most of our patients are a local cohort, we really try to follow our patients very closely and also follow the family members. So when a family comes in and one kid develops reactive arthritis, another kid develops a PANS episode, and the mom develops a psoriatic rash, all at the same time, and another kid had strep, well, we know that family is strep sensitive because psoriasis, reactive arthritis, and PANDAS symptoms can all come after a strep infection. So when we study the family's pattern and it looks like that it's a post-strep case, then absolutely penicillin prophylaxis is what we do. If the family cannot be compliant with 250 milligrams twice a day, then sometimes we use amoxicillin, but we really try to use penicillin. And then other than that, we're really not using a lot of antibiotics. We do use azithromycin, but we're not using it for the antibiotic property. We're using it for the anti-inflammatory property.
Understood.
But yeah.
Okay. And then,
the microbiome, we just use the sort of standard Fluorostor and Culturelle that's, sort of been used in the pediatric studies. If we're treating sinusitis and we use something like Augmentin, then we'll use one of those probiotics to prevent C. difficile.
Great. And then just one last question, and then also, can we share your slides, Dr. Frankovich?
Yeah.
It's like kind of putting you on the spot because I have 200 people watching that question, but is it okay if we share with the attendees?
Yeah.
Okay. So that, and then,
you know what? You mean share the actual slides or share the...
We don't, is that okay or not?
I would have to first look through them and make sure that, some of it's still preliminary data. So okay. I think it would be better if we published the data first. Okay. Just because, it's, I don't want things falsely distributed and it's false information. So, yeah. And I think on the slides, I was clear that it was preliminary, but I think it still would be best to wait.
Okay. No worries. And then last one. So it's similar to the Cunningham panel. How helpful is an LP in making diagnosis of PANS and PANDAS?
So it's not helpful in making the diagnosis of PANS and PANDAS because we haven't figured out a biomarker in the CSF that's associated, at least that's available to the community. We do LPs when we think that the case may be consistent with another form of encephalitis, like NMDA. So some of our patients, even though it's a classic PANS presentation, maybe their OCD is actually bordering on psychosis, and in that case, it could be NMDA receptor encephalitis. So we would do an LP if we needed to rule out NMDA receptor encephalitis. And then in those situations, we are getting research specimens, and we're studying those research specimens, and we have some preliminary ideas of what some good markers are, but we're still, several years away from really coming up with a good biomarker.
Okay. Well, Dr. Frankovich, thanks so much again for your time, your expertise, your knowledge. It was really greatly appreciated and really well attended. I'm just going to close with a couple of remarks. So number one, guys and gals, thank you for participating in today's CME activity. To receive credit, please complete the registration evaluation form that you will receive via email and is available under the CME tab of our website, neuroimmune.org, and return it by email. Certificates will be issued within 10 business days of receipt. The email address is listed on the form. The last thing is, I do want to put out a shout out to all the people who attended to be aware of the PANDAS Physician Network, which is pandaspn.org. It's something that physicians can join. You get a lot of support, advice, and guidance on diagnosis and treatment and a lot of the issues that Dr. Frankovich addressed. And so I just want to put that out as a really good resource to the folks who joined. And with that, I'm just going to say have a great day, good evening, and thanks a lot, Dr. Frankovich, once again.
Thank you. Take care.
Bye now.